survival in all patients with a combination of treatment and especially with some new and biological and personalized treatment. So with this, I thank you everyone, and I'd like to invite all of you to our next ESGO meeting, which will take place at the end of the year. We hope live, otherwise it will be we hope on site, otherwise it will be on live in Prague in October 2021. Thank you very much. Good morning, everyone, and thank you.
Thank you very much, Professor Fagotti, for this nice presentation. And now, if there is any comment or any questions. Yes, Professor Sikutori.
Thank you very much, Mr. Chairman. My question to my dear friend, Professor Thomas End from the United Kingdom. We have been, into the problem of testing all patients before going for major surgery for gynecological cancers in one of the hospitals that I work in, where there is a delay in getting the results and being assessed because those who assess them are not the surgical team, so they don't know or they're not fully aware of the precious moments and minutes of running theaters and surgical departments and all this. The turnover from a patient coming to the hospital to have admission until she gets the results of her having a negative COVID test being admitted to her room is about 3 to 4 hours at the moment. Do you have such experience in the UK?
Yes, I can answer that question both as a. Sorry, I think it might be my anaesthetist inviting me to theatre. I have experience both both clinically, because if you remember, we originally had no such tasting. We just told people to self-isolate, which, as you know, the British people aren't very good at self-isolating. They think self-isolating means that someone else has to do it. As long as they can go to the supermarket and give their children a hug when they get back from school, it's okay. So we basically, all the surgeons are getting PCR tested every week. There's no such thing as no risk, but you can reduce the risk. So we're testing our patients 72 hours before. And interesting, I don't know if you know, I'm sure you know I've had a cardiac stent put in the last few weeks or so. And when I was admitted, I got a COVID test 72 hours, and then I got a lateral flow test on admission. So, you can't eliminate risk, but you can certainly reduce it. But in the early days, we had a mortality of somewhere in the region of 20% if you got tested positive and got intubated. But that's not the case since we've got steroid immunotherapy.
Okay, Professor Abdelhadi.
Okay, thank you so much. Very interesting talks, but perhaps I would ask both the last two speakers, Professor Ramirez and Professor Fagotti, regarding the best management or triaging patients with advanced ovarian cancer. If the evidence from both of your talks that there is no benefit for overall survival or progression-free survival of either neoadjuvant chemotherapy or upfront surgery, then now every case is personalized. But my question is, during our tumor board meeting, physicians, in particular the medical oncologist, would push towards neoadjuvant chemotherapy, and surgeons in particular would push towards upfront surgery. And in most of the cases, we don't have the evidence to defend either or. So based on both of your talks, until we have a robust evidence, what is your advice? Should we carry on personalizing based on the patients and on the physicians, or should we be towards medical or surgical aspects? Thank you both.
Anna, do you want to go ahead and answer first?
Yeah, please.
As you like.
Yeah,
Go
that'd
on.
be great. Mhm.
Go on. If you want, you
Oh,
can.
okay. Yeah. No, I mean, I think certainly, I think that's a very good question. And obviously, there is evidence that for some patients, the best approach would be surgery. And that, again, is particularly patients where we see that we have achieved an R0 cell reduction. I think the issue is that how to predict which patients are going to have that R0. And I think that that's where it is critical to make sure you have adequate, very adequate imaging studies, very adequate imaging reports, certainly to have a tumor board or a disposition conference, as we do in our institution, where each of the imaging studies are reviewed and evaluated, where one also takes into consideration the frailty of that patient, how likely that patient is to have complications from surgery. And I think it's very routinely that we as surgeons often will be the ones recommending neoadjuvant chemotherapy for some patients, and then for other patients, obviously advocating for surgery. And certainly the same from the groups of medical oncologists, where they, certainly if there is a patient that seems to potentially benefit from surgery, that patient should go to surgery. So I think that this all or none, it's not the best for the patients. I think that, for any surgeon who basically says, well, I just operate on everybody because I'm such a fantastic surgeon, obviously that's not ideal for the patient. So back again, I think is how to select the best patient, and adequate imaging studies, laparoscopic evaluation, I think it is key in determining which patients to go to neoadjuvant chemotherapy. And lastly, I will say that there is this concept, and often by many surgeons, who feel that if we give neoadjuvant chemotherapy, then that's horrible and that's detrimental for the patient. It doesn't mean that can apply to every patient. There are patients who are going to be best treated by neoadjuvant chemotherapy.
Okay.
Yes, I agree. I mean, it's not always an easy evaluation, and this is why we are trying to classify everything we do. So anytime we have key points of unresectability, or anytime we give a score, it's a way to make everyone happy, because we must agree at least on some points. And if we give numbers and scores, probably it's easier. So to each number, we have a rate or a percentage of patients responding or having a complete gross resection. And so this is how we can achieve an agreement in the best way.
Yeah,
Professor
Professor Gamal.
Gamal Amira?
Yes, Professor Gamal Amira.
Mike, please.
Is it possible to add a few comments to that question?
Yeah, please. Yeah. But we'll have a question here from the floor, and then we'll listen to you, Raj.
Okay. Sorry, do you want me to go ahead, or?
He is coming. Just a minute, please. Okay.
I'm Professor Gamal Amira, National Cancer Institute. When you do the laparoscopy, you do the surgery the same day, or you have the findings and you discuss again with the committee by the findings and by the calculation and index. You calculate them with the group or the committee, and then you go another day for surgery, or you do after laparoscopy and assessment, and you have the decision that you can go to surgery, or you have to discuss it again with the committee.
Yeah, did you get the question? The question says, after laparoscopy, do you go ahead, proceed to surgery, or do you revert back to the committee and try to discuss things and come back at another session?
I can answer very quickly.
Yeah, please.
So in my institution, we do it immediately. It's rare that we go back to one patient after laparoscopy. It may happen, for example, if the histology at final examination is different from the frozen section. And so there are some cases where we come back, for example, in low-grade tumors, but most of the cases we do it immediately. We discuss within the OR. We have at least 2 senior surgeons to decide whether or not proceeding with one treatment versus the other, and there must be agreement between us before concluding the surgery or going on with surgery.
Okay, Raj, could you go ahead? Raj, do you hear me?
Maybe we'll have a last comment
would
from
like to
Professor
comment?
Scottori.
Yeah, with regard to the laparoscopy assessment before operating on advanced ovarian cancer, it is tempting, but it's not as easy as it has been projected. With the lots of pressure demands on theater capacity, on doctors, and I'll tell you what we did at the Christie in Manchester. I liked the really organization of that system because it puts into consideration a cost efficiency in terms of how to have a very high throughput of the cases. We grouped cases into group 1 where there's no doubt that surgery will benefit them, and this is based on the desktop 1 and then desktop 2 trials. And there are cases where it is really sure that they don't need surgery. They can't have surgery at the beginning, so they have a neoadjuvant chemotherapy. And those borderline cases, we did laparoscopic assessment for them. There's also another group after the neoadjuvant chemotherapy where we assess them laparoscopically for the feasibility of doing the whole surgery laparoscopically. Those who had the complete remission, biochemical and radiological remission following surgery. Is this the case at your centers, or you do laparoscopy in all cases?
I'll just answer for MD Anderson. No, we do not do laparoscopy on all cases. There are a number of patients that already are coming in with evidence of distant metastases. Those patients obviously do not go to laparoscopy, or patients where there is interparenchymal liver disease. Those patients don't go to laparoscopy. Or if there is evidence of extensive disease in the lesser sac or disease at the root of the mesentery, that is a retraction of the root of the mesentery,
Exactly.
then those patients do go to laparoscopy, because regardless of what you find at laparoscopy, that patient's going to go to neoadjuvant chemotherapy.
That's good.
Okay, Raj, you still have a comment. Would you please go on?
Yeah, thank you very much. I have 2 comments. First is, I think each surgeon needs to decide or determine what their rate limiting step is in achieving R0 cytoreduction, because it's going to be different for different surgeons. So if it is disease on the small bowel, then it's correct. Laparoscopy may provide assistance in showing you disease on the small bowel and therefore selecting that patient for neoadjuvant. But for every surgeon, there will be a different factor that determines whether they're able to achieve R0. And I think the second factor is also that if Andres Dubois was here, for instance, he wouldn't call a laparotomy in itself as being futile. He actually uses laparotomy as a means of assessing cytoreduction. So to carry out a mini laparotomy incision and doing a thorough and complete evaluation of the porta hepatis, the root of the small bowel mesentery, the whole of the diaphragmatic areas, actually provides a better assessment than radiology or laparoscopy in determining whether complete cytoreduction is achievable. Now, doing a mini laparotomy does not mean you have to then proceed. Patients have to be counseled preoperatively that the initial laparotomy is an assessment, and it's only at the assessment is it going to be determined that they're going to proceed to full cytoreduction, or whether the procedure is then going to be diverted to a primary chemotherapy route. So I think there's nothing drastically bad or wrong in carrying out a mini laparotomy assessment.
Great. I think Professor End is raising his hand. Would you like to comment, please?
Yeah, I would just like to reinforce a couple of comments. We don't routinely laparoscope people. We do occasionally, and I've done a few colonoscopies in my time, laparoscoping people. Laparoscopy in itself isn't without complications. I think Pedro's comment about the radiology is really important. I would look at every set of films of my radiologist before going into theatre. The report is important, but to be honest, I'm much more interested in sitting down with Aslam, my friend and colleague I've worked with for 30 years, and to look through the films with him, because he's so much better at doing it. And I don't like laparoscopy because it's very difficult to assess the porta hepatis in laparoscopy. I've got to be honest, I can't really do it. All those little areas which are difficult to get to, which are the real fundamental areas which are difficult to reach when you get a laparotomy, you don't really help you with laparoscopy. So I'm not a fan of it. I think opening a patient's tummy up is better, and every now and then you're going to